Good morning in Hong Kong and Asia, and good evening in the United States. I'm Eric Chen from Queen Mary Hospital. It is my great pleasure to welcome all the participants, both online and physically here at the Ocean Park Marriott Hotel, to the second day of Hong Kong Valve 2021. Yesterday, we are honored to have 19 overseas speakers and panelists from the United States, Canada, the United Kingdom, the Netherlands, Denmark, Spain, Japan, South Korea, and China to give us their excellent lectures and discussions. 6 different TAVI devices, namely the Evolut Pro Plus, the Transfemoral J-Valve, Allegra, Accurate Neo 2, Navita, and the Sapien 3 have been showcased. We also have the latest updates on coronary physiology in aortic stenosis, transcaval, transcarotid, and transaxillary TAVR, the Basilica procedure, minimally invasive surgical AVR, as well as updates on cerebral embolic protection with the TriGuard and Sentinel devices, and vascular closure with the Manta device. Today, we are fortunate to have all the eminent speakers and panelists who are top-notch experts in mitral and tricuspid valve imaging and interventions. You have come to share your expertise in state-of-the-art advancements in structural heart interventions. I wish all the panelists and participants a stimulating and rewarding day of discussions. Thank you. Today, we have our first session focused on tricuspid valve. Let me introduce our expert panelists and speakers. First of all, we have our overseas panelist, Professor Kentaro Hayashida. He's the Director of Transcatheter Heart Valve Program and Cardiac Catheterization Laboratory in Keio University School of Medicine in Tokyo, Japan. He's published extensively in the field of interventional cardiology and holds faculty positions in a lot of international conferences, such as being the course director of PCR Tokyo Valves, co-director of AP Valves, London Valves, and Asia PCR. Then we are glad to have Dr. Daisuke Hashinohe, who is the Chief of Cardiology Department and Director of Structural Disease Center of the renowned Sapporo Cardiovascular Clinic. He has also published extensively in the field of interventional cardiology and is an expert in mitral clip as well as transcatheter heart valve implantation. Then we have our local experts. First of all, we have Professor Alex Lee. He's a professor of medicine and is the director of echocardiography and the director of Laboratory of Cardiac Imaging and 3D Printing in the Chinese University of Hong Kong. He's also the coordinator of the echocardiography chapter in the Hong Kong College of Cardiology. Then we have Dr. Yuk Kwong Lau, who is the past president of the Hong Kong College of Cardiology and is the founding chair and program director of the renowned cardiology conference, Echo Hong Kong. He was also the chief of cardiology in the Rutenji Hospital. Then we have Dr. Eric Wong, who is the consultant cardiologist as well as director of echocardiography laboratory in Queen Elizabeth Hospital. He has vast expertise in interventional echo during structural heart interventions. Then we have Dr. Daniel Chan, who is our consulting cardiothoracic surgeon in Queen Mary Hospital, and of course, the founding program director of Hong Kong Valve. He has vast experience in heart transplantation, valvular surgeries, and coronary artery bypass grafting. He has been our leading surgeon in both transcatheter procedures and minimally invasive cardiac surgery ever since the partner trial era. Now, may I have the honor to introduce our distinguished international speakers. First, we have Professor Rebecca Han.
So
Should
I go ahead and
thank you,
start
Professor.
off? Yeah.
Let me, good to see you. Professor Rebecca Hahn is the Professor of Medicine at Columbia University Irving Medical Center, Chief Scientific Officer of the Echo Core Lab at the CRF, Director of Interventional Echocardiography at the Columbia Structural Heart and Valve Center. She has published over 250 articles on echocardiography and valvular heart disease and has co-authored various American Society of Echocardiography guidelines. In recent years, Professor Hahn has revolutionized the tricuspid valve imaging by proposing a new TR grading scheme, which includes massive and torrential TR. She also has devised a new classification scheme for tricuspid valve morphology to recognize tricuspid valve with not just 3, but also 2, 4, and more than 4 leaflets. She was the national PI for the SCOUT trial for the mitral line annuloplasty system and is the national co-PI for the TRISCEND pivotal trial, which studies the evoked valve from Edwards on the tricuspid position. Then we have Professor Rvpa Coupling, whom we had the honor of his presence in Hong Kong 4 years ago. Professor Coupling is a professor in cardiothoracic surgery in Guy's and Thomas Hospital, London, and a cardiothoracic surgeon and researcher in the Minneapolis Heart Institute Foundation. He specializes in minimally invasive and percutaneous treatment of structural heart disease. He has numerous publications and is a true pioneer in the field, and we all know him for the creation of 2 mobile apps, Valve-in-Valve Mitral and Valve-in-Valve Aortic. These apps provide important imaging and clinical information for various surgical prostheses and have been downloaded in 132 countries, guiding physicians and surgeons worldwide. Last but not least, we have Professor Gilbert Tang, who is the Surgical Director of the Structural Heart Program at the Mount Sinai Health System and a Professor of Cardiovascular Surgery at the Icahn School of Medicine at Mount Sinai in New York. Professor Tang is leading a number of multi-center research projects in structural heart disease, including the global Explanterra and cutting-edge registries. He is also famous for pioneering the CUS overlap technique to optimize self-expanding TEVR deployment and the commercial alignment technique to preserve coronary access. So without further ado, let's introduce Professor Rebecca Hahn. For her first lecture, she will talk to us about the imaging of the tricuspid valve regarding the anatomy, severity, and pathophysiology. Thank you, Professor Hahn.
Thank you so much. Really thank the conference organizers for inviting me to speak today. We'll be concentrating mainly on transesophageal imaging. These are my disclosures. We'll start first with anatomy and the comprehensive TE evaluation. And to understand how difficult it is to image by transesophageal echo, you can just look at the path of the esophagus with respect to the annular plane of the tricuspid valve and see that it's very difficult for us to get perfectly coaxial with the annular plane in order for us to see the leaflet swell. And in addition, because the esophagus is very posterior and the tricuspid valve is very anterior, we're now imaging in the far field of our TEE probe. And so we've felt the need to update our TEE guidelines because we now understand the path of the esophagus. And so these will be coming out online in November. We're now in the final stages of the proofs, and where we have 5 probe manipulations and 5 advanced imaging modalities, we've now added a 5th level of imaging, and that's the deep esophageal view. And we'll cover all of those imaging views that are specific for the tricuspid valve, namely the mid-esophageal, the deep esophageal, transgastric, and deep transgastric views. So if we start from the mid-esophageal view, clearly, again, remember the tricuspid valve is at about a 45-degree angle typically from our insonation beam. And so we have a very hard time getting over the dome of the right atrium. And therefore, these are the classic 0-degree and biplane views of the tricuspid valve. But this is where we can see the entire free wall of the right ventricle, and therefore where we will do much of our analysis of the right ventricular function. We also like to use from any plane where we get a good image of the tricuspid valve, real-time 3-dimensional multiplanar reconstruction. This allows us to image not only the coaptation gap, the number of leaflets, but also measure the leaflet lengths in order to determine whether or not a TEER device, a transcatheter edge-to-edge repair device, will be possible. From the mid-esophageal views, we like to go into what's called the commissural view for the tricuspid valve, and this is the inflow-outflow view, where now you see the aortic valve, the tricuspid valve, the right atrium going to the right ventricular outflow tract. And this, when you look at the three-dimensional image of that commissural view, you now can understand that the septal leaflet is in the far field, out of plane of the two-dimensional image. And that when you then scan across this inflow-outflow view from the aorta to the posterior wall of the RV, you now are scanning across the coaptation zone of the entire septal leaflet. And so this becomes a really important view for us when we're trying to determine where the regurgitant orifice is. We also have a number of different modalities that we, new software really, that we're using for this inflow-outflow view that allows us to align perfectly with the coaptation zone, and in this case, with the clip arms of a tri-clip device. And so this new software allows us to have a user-defined tilt plane instead of a perfect 90-degree view all the time. We also have live 3D MPR, as I mentioned before, and this allows us now to, the newest software allows us to align vertically all of the two-dimensional long axis views, and then to realign our short axis views so that we're consistently seeing from any view the same image for the interventionalist. And this allows communication with the interventionalist to be improved. The deep esophageal view is one of our favorites because this allows us to image the tricuspid valve without any intervening left heart structures. And because functional tricuspid regurg is the main etiology of the regurgitant pathology that we see, we often have prosthetic material on the left side of the heart that we have to avoid in order to reduce the acoustic shadowing. And so the deep esophageal view is one of the best views to do that. Now, the transgastric view, again, is a major view for us because the tricuspid valve sits on the diaphragm. Because it sits on the diaphragm, we're now very, very close to the leaflets, and this is the only two-dimensional view where you can see all three leaflets coapting. Again, because of that, we are able to count the number of leaflets. We're able to see where the regurgitant orifice is. We can acquire three-dimensional imaging, both without and with color. And this really allows us to characterize more fully the tricuspid valve. But in addition, the transgastric views allow us to look for chordal abnormalities or dense chordae, as well as papillary muscles. When we identify the papillary muscles, we are then able to determine the morphology of the tricuspid valve. And this is the paper that was referred to earlier, where we took 576 patients from 4 different institutions, 2 in Europe, 2 in the United States. And we were able to identify tri-leaflet valves in 54% of patients and other morphologies in the rest. The most common, second most common morphology is a quadricuspid valve, and this is the 3B quadricuspid valve. Now, in order to determine where the number of leaflets and whether it's a posterior or an anterior extra leaflet, we're looking for the anterior papillary muscle. So the anterior papillary muscle from a transgastric view is indicated here with the yellow arrow, and therefore divides the anterior leaflet from the posterior leaflet. And so in this particular patient, you can see the papillary muscle, anterior papillary muscle is where I'm circling, and therefore the 2 leaflets posterior to that leaflet are now the P1 and P2 leaflets, making this a 3B conformation. And it becomes important in the end because when we're doing the TEER devices, transcatheter edge-to-edge repair, there have been some papers already suggesting that technical success may be slightly less in those patients with quadricuspid or even more complex valves. We do like to use the transgastric view in order to perform. This happens to be a Pascal device, but using 3-dimensional imaging, we can actually see the leaflet grasping and obviously the closure with adequate bridge and reduction in tricuspid regurgitation. Finally, the deep transgastric view allows us to do all of our Doppler assessment of the tricuspid valve and be on axis versus the mid-esophageal views where we are now 45 degrees from being on axis to flow. This view, the deep transgastric view, allows us to, similar to an apical view, perform all of our Doppler measurements. So how do we assess a disease severity? Well, the disease severity is a little different from just tricuspid regurgitant severity. If you look at the new European guidelines, clearly there are 4 steps in order to determine when to intervene on these patients, and that's to determine the tricuspid valve etiology first, then regurgitant severity, assessment of the right heart, and then determination of pulmonary hypertension. And normally we would divide TR etiology into 2 groups, primary and secondary. However, together with the tricuspid group from the PCR, and we're now generating new documents in Europe, we now have proposed a different classification where we do divide into secondary and organic primary, but there is a separate category of pacemaker-induced tricuspid regurgitation, since that's neither primary or secondary. And in looking at the different types of morphologies for functional disease, this beautiful paper using 3-dimensional transthoracic echo was published by Denise Moraro. And in this paper, she showed that the best predictor of severe tricuspid functional regurgitation is the size of the annulus and the size of the right atrium. So markedly different from a normal or even patient with tetralogy of Fallot. And next, when you differentiate ventricular functional from atrial functional, you see that those patients with ventricular functional, whether from pulmonary hypertension or left heart disease, have markedly dilated right ventricles, but also marked tethering of the tricuspid valve leaflets. And then finally, when you look at atrial functional tricuspid regurgitation, there is less dilatation, although still some, of the right ventricle, not as much tethering, but markedly dilated right atria. So on transesophageal echo, when you're looking for the etiologies and the morphologies and classify the TR, then we're looking for the leaflets for prolapse, or in this case, a flail septal leaflet, and for CIED, or a cardiac implantable electronic device pacemaker related tricuspid regurgitation. We're now looking for impingement and adhesions of the leaflets or the subvalvular apparatus to the pacemaker. For atrial functional, we're looking at a leaflet closure at the annular plane, right ventricle maintaining its conical shape, and a markedly dilated right atrium. Whereas with ventricular functional, we're looking for a markedly dilated right ventricle compared to the left ventricle. You may have atrial dilatation as well, but the tethering of the tricuspid leaflets becomes the primary mode of regurgitation. And it's important to do that type of classification because we know outcomes depend on the classification, where isolated, which used to be called isolated, is now atrial functional regurgitation, has perhaps the best outcome compared to congenital or organic, i.e. prolapse, and that the ventricular functional disease has the worst outcomes. And so again, very important to know the etiology. The next step is to determine severity, because we know that with every increased grade in severity of tricuspid regurgitation, there is worse survival. And so in order to do that, the guidelines recommend that we use proximal ice velocity surface area to quantify the regurgitant orifice area and then calculate the regurgitant volume. But this method cannot calculate regurgitant fraction directly. You need another method. And those other methods could include the volumetric Doppler method, which can calculate all 3 parameters of severity, and then 3D color Doppler, which again can confirm vena contracta area, which is the equivalent of EROA, and calculate regurgitant volume. So this is an example of TEE quantification by PISA, and when you do the calculation, you have to bear in mind that the tricuspid valve is a really unusual valve. As I showed you from the transgastric views, it tends to have an elliptical or star-shaped orifice. It tends to have multiple jets. And so in that setting, the PISA becomes less accurate and tends to underestimate the severity of disease. We know also that in non-planar leaflets, PISA also will underestimate, particularly for leaflet tethering. We also know that under low pressures, we frequently have to use a flow correction. And then finally, this is a transthoracic view, but showing the bimodal length of the Pisa radius. So this is a very temporally variable jet. And because of that, Pisa is really not felt to be a perfectly accurate method of quantifying regurgitation. And yet there are many outcome studies showing that a Pisa of greater than 35 or 40 millimeters square is associated with increased mortality. So we will never abandon the use of Pisa because of the outcomes already associated with it. But what we like to do in our lab is quantitative Doppler. And you can do it either by measuring a biplane annular dimension and putting that into an elliptical formula, or our preferred method on transesophageal echo is to actually directly planimeter the annular area. Then you can quantify regurgitant, the total stroke volume across the tricuspid valve, subtract the forward flow, and get the regurgitant volume. And the advantages to that is that with multiple and temporally variable jets, you can still quantify with quantitative Doppler. But the disadvantage is obviously the number of measurements that you have to do and the assumption of a constant flow across the annulus. Now, 3D vena contracta has become a really attractive way of quantifying disease. And you can see from this graph that what we do is we use the 3D color Doppler in order to cone down on just the vena contracta, and then we directly planimeter the orifice. And the advantages to that is that it has no geometric assumptions, and it can definitely be used after device placement, making it one of the primary ways that we have of assessing regurgitant severity. But in addition, the disadvantages are that because of the temporal variability, we often have to integrate a number of measurements over the cardiac systolic time interval. But this is just a summary of the measurements that we do on a routine basis from our transesophageal echo in order to quantify tricuspid regurgitation. And we've also looked from our core lab at the various measurements, and we now understand that Pisa underestimates by almost twofold either 3D vena contracta area or the Doppler effective regurgitant orifice area. The third step is to assess right ventricular size and function. And so one can use transesophageal echo. And remember, I showed you the 0-degree midesophageal view where you can see the entire right ventricle. And it turns out from this study that indeed the fractional area change from the midesophageal views were not significantly different from the FAC performed on transthoracic imaging. What about other measures? Well, when you look at the anatomic M mode from a midesophageal view, so this is, they're able to now maintain this 45-degree angle along the annular plane, then that measure was also not significantly different as far as TAPSE from the transthoracic views, and that the transgastric TAPSE and S-prime views, which have been previously suggested, actually significantly underestimate. So our method is actually to continue to use the midesophageal views, and actually instead of an M mode, we just fix a point in space and along the line of longitudinal shortening and measure the diastolic and systolic lengths and subtract to get the TAPSE. We also know that RV strain has now become a very important measure of RV function for tricuspid regurgitation. This is a patient that has the evoke valve where we see a marked drop in the RV strain, and we do believe that this will be one of those measures that may predict outcomes in the future. And we also know that pulmonary hypertension is also a predictor of outcomes in patients after transcatheter edge-to-edge repair, and that precapillary pulmonary hypertension has the worst outcome. And so the only pitfall here for echo is that about 23% of patients may have discordant measures from invasive, and that was shown by Philip Lurtz in this paper. But we can predict which ones those are. They're going to be this patient here that has the triangular-shaped torrential disease, worse LV and RV function, and it is indeed those patients that end up having the worst outcomes. And so when you look at the new horizon for us, which is going to be the transcatheter devices, we now use echocardiography to pre-procedurally screen. We know that there are a number of pitfalls of all of these devices, which I'm sure will be covered in the ensuing lectures. And particularly, I think Dr. Rvpa will talk about transcatheter valve replacement devices, knowing that we have, again, a number of pitfalls that need to be overcome. And the one pitfall where we have difficulty imaging, which may which may favor the replacement device, may be superseded by these recommended standard images, where if we can train the echocardiographers to perform all of the images that I've just covered, then I do believe that we'll be able to perform the procedures. But in addition, we now have 3D intracardiac probes, which will be greatly beneficial to this particular valvular disease. Thanks for your attention.
Thank you, Professor Han, for your work and your insightful and groundbreaking advancements in imaging of the tricuspid valve. Now we are open to discussions with our overseas and local panelists.
Can you hear me? Becky, hello, I'm Alex. Nice to see you again.
Hey, Alex.
Thank you for your excellent talk as always. If I may, I have two questions for you. So first question is that what TE view you usually use for guiding the steering of the triclip, meaning from the insertion to the right atrium from the IVC, and then they have to bend the clips and then steer towards the target site. So in the mitral clip, we use 3D echo a lot from surgeon view. Do you use similar compatible view for the triclip for steering? That first question.
Yeah. That's a great question.
Yeah, the second question is that when there are more than 3 leaflets in your in a tricuspid valve, how do you determine where you put the first clip, or how many clips you usually put for a 4-leaflet tricuspid valve?
Yeah, those are great questions. So for the steering, we start with a bicable view, but have a bicable on 3D. And so the bicable on 3D allows you to see the device coming in and avoid the interatrial septum, because depending, with elderly patients, the angle of the IVC and SVC to the right atrium have changed. And then in some of them, the angle from the IVC into the right atrium actually points toward the interatrial septum, and you don't want to hit that or go through that for the tricuspid valve. And so we like to use the bicable view, but on 3D. So we just turn on live 3D, we watch the device coming in, and then you can go ahead and see it bending down toward the tricuspid valve. From there, we immediately switch to the inflow outflow view, mid-esophageal inflow outflow view, but use live 3D MPR in order to align ourselves with the device and determine the trajectory of the device to get it perfectly perpendicular to the annular plane. And then from there, it all depends on how much shadowing there is. Frequently, we'll use either mid-esophageal or deep esophageal in order to guide the device down, maintaining a quad screen where we have 3-dimensional imaging in one view so that we can see the orientation of the clip arms. And then not infrequently, we confirm, frankly, in every case, we confirm the orientation of the clip arms from a transgastric view, whether or not you use 2-dimensional, or we prefer 3-dimensional multiplanar reconstruction, which gives you obviously 2-dimensional and 3-dimensional images in order to align the clip arms perfectly. And also, as I think I showed you in that one view, you're actually able to, on 3D, see the leaflets go into the base of the arms, and then to see the device closing on the leaflets, measure leaflet lengths, determine whether or not you have a good bridge. I mean, transgastric views end up being one of our major views as well. And then the other question, I forgot.
4 leaflets. 4 leaflets. Where do you put?
The 4-leaflet valve. So what we like to do is first look at the color Doppler, and so there's a couple of things that will determine where you go. One is obviously as always, leaflet length and coaptation gap. And so if you have a 4-leaflet valve and can actually see the regurgitation between the septal and the anterior leaflet, then you're pretty sure you're going to want to put at least one clip there. Then in addition, if you have jets, which you typically do, between P1, P2 and the septal leaflet, then you're going to need another clip. And the issue really becomes how much septal leaflet length you have in order to fit 2 clips on the septal leaflet. Right. And typically we're not going to put three on. We're not going to get the P2 most commonly. And so sometimes we learn to live with a little bit of regurgitation coming from the P2 septal commissure. And that's just a fact of life. Now, I would never have done this, but we saw once a live case where they actually went anterior to P2, which is not something that I've ever done. We were all watching with amazement because we were a little nervous that they were going to open up a gap somewhere. And it was a perfect result. It was a perfect result. So we're still learning a lot about these quadricuspid valves. I think there's a lot of options that we haven't considered in the past, and just still learning. In general, if you have a 5 leaflet valve, those become really difficult, and we start to think about a replacement device.
Right. Thank you. Thank you very much.
Hi, Rebecca. Hi,
Yes.
HKvalve from Hong Kong, and always a pleasure to listen to you and learn from you, and always great presentation. I have a question for you. What do you think about the role of the transnasal echocardiogram? Is it a useful tool will be evolving to guide us in intervention, or is it still a toy right now?
I'm sorry, the ICE probes?
The transnasal echocardiography?
The very small probe. So we tried that, and the issue really is the depth of field. So it's a super small probe. So the smaller the head of your probe, the worse, the depth of field. The shorter the depth of field. And so when we tried we tried it actually orally, but either way, it still required. It needed some work. But having said that, we are working with, in particular, we're working with Philips, but I'm sure there are other companies that are trying to develop the mini TEE probe. And it has some great utility, I think. If we are able to, for instance, do all of these procedures not under general anesthesia, I think that's going to be a significant advantage. So we're working with them. They've got some great solutions, and I think in the future, right now, we don't have a probe that I feel comfortable using, but in the future, I think we might. The one thing that we had great hopes for was the 3D ICE probe, but I still think that there are some limitations again to the depth of field. So now we're talking about a really, really, really small head of the TEE of the probe, of the echo probe. And so the depth of field again becomes a significant issue, even though we're actually inside the heart. So we'll have to see. We haven't had a lot of success yet using some of these ancillary tools, but I think they're still in development. And we have great hopes.
Thank you.
Hello, Rebecca, this is Eric Wong from Hong Kong. So I have a question regarding the presence of prosthetic valve on the left side. So I think it is rather common for us to see some tricuspid regurgitation case with pre-existing prosthetic valve metallic or bioprosthesis, and it poses a very great challenge to image the tricuspid valve by TEE. So do you have any comments or recommendation or any modification of the protocol when there is a prosthetic valve?
That is a great question, because now, obviously if we have prosthetic material on the left side, we can avoid it by just going deep gastric. But the prosthetic tricuspid valves, acoustically shadow themselves in almost every view. And so the deep esophageal still allows us probably a slightly better access from an inflow-outflow view. And so if you get the inflow-outflow, you feasibly can get a slightly better image. But remember that the valve itself is from almost any esophageal view is still tilted about 45 degrees or more. And so we're always going to be subject to the shadowing, acoustic shadowing of the prosthesis itself. And so it does become really, really difficult. And in some of those patients, if you're worried about paravalvular, we end up getting CT scans. And we're looking now for the gap and dehiscence of the sewing ring. Color Doppler can sometimes help us, obviously, determine exactly where, but the acoustic shadowing is really, really an issue for prosthetic valves.
It just a follow-up with that. actually we have done some cases of mitral clip in tricuspid position in the presence of prosthesis, and we found that sometimes the transesophageal echo images during intra is quite terrible. So do you think a combination of eyes plus TEE would help, or you'll just go for eyes alone?
Yeah, there have been cases with ICE alone. There have been a number of cases. The issue that I have with 2D ICE is that you really have to align. It's not as easy as it seems to align the imaging plane to see the two clip arms and to see the leaflets going in. And, you know, SLDA rates have ranged, you know, anywhere from 5 to 7% of the cases. So it's something that needs work. And what we have advocated for is using two different methods to make sure that you have enough leaflet inside the clip arms. And so my problem with 2D ICE is that I'm always worried that you're not actually seeing everything you need to see. Now, 3D ICE, people have used some of the new 3D ICE probes. So the one that's the oldest now is the Siemens device, but that is a circular array, not a phased array. And so its depth of penetration and also image quality is somewhat, leaves something to be desired. And so, but people have used it. So I do believe, I think you're right. It may be a combination. We have all these new software modalities too, so that we can now, instead of having an orthogonal, the secondary biplane view be orthogonal, being 90 degrees all the time, we can rotate it so that we can actually see clip arms really well, even with prostheses, because the inflow-outflow view tends to get the prosthesis away again from the shadowing. And so using the biplane from an inflow-outflow with the tricuspid kind of pulled over to the side of the sector is a great view for in the setting of left-sided prosthetic material. But I do think in the end, if we have any trouble, it'll end up being a combination of TEE and ICE.
Thank you.
Thank you. We have a question from the floor from Dr. Au, who is our Chief of Cardiothoracic Surgery. Dr. Au, please.
Thank you, Professor Han. Nice talk. Now, I have one comment and I have one question. First, a comment. Now, you mentioned that you come across a tricuspid that have more than 3 leaflets. Now, with my 20 years of tricuspid surgery, I've never encountered a quarter leaflet tricuspid valve. I think the phenomena or whatever you've seen in the TEE is actually a major cleft at the anterior leaflet, because I've never seen a full commissure in tricuspid valve, despite all the other congenital or even the post-TOF with all these repair at the VSD. So I think that would be the imaging you get with a big cleft at the anterior leaflet.
That's a great comment. We have in that manuscript a figure from Leipzig, and this is Michael Borger doing a minimally invasive tricuspid annular repair, where we identify the 4 leaflets, and he actually identified it. This was a live case, and he identified them intraoperatively as 4 leaflets. But I don't disagree with you that sometimes what we're seeing are just deep folds or maybe clefts and not true leaflets, with the leaflet going all the way to the annular plane. But for the procedures and for the echocardiographer, it's the same. So in the paper, we state the fact that sometimes we can't tell that it's a true leaflet or it's really just a very deep fold or a cleft. But to us, it means the same thing because we can't get the clip arm on it. It's just too deep a fold, it's too deep a cleft. And so in the manuscript, we clearly state that we have limitations, in using, it's not the same as your visualization, but one of the sites that participated and contributed over 200 patients was indeed Leipzig, and they had the same prevalence of the disease, of the different leaflet types that we did. So it may be also the patients that are coming to surgery. Maybe there's a difference. I don't know, but I agree with you that sometimes we aren't identifying leaflets, we're identifying folds.
Thank you. Thanks for
I
clarifying that.
think, may I chime in here? I think what we're seeing, maybe what we see in mitral valve, right? Mitral valve is two leaflets, we know that, but there are three segments in the posterior leaflet, P1, P2, and P3. And sometimes you see these deep indentations. So I think what Becky's classification morphologically is quite similar. You have basically, it's not two posterior leaflets, like P1 and P2. That's how we actually categorize it. And I think from a transcatheter therapy standpoint, it's very practical versus surgical, which we can in the operating room do whatever we want to address the issue.
Thank you. Can I have a question for Professor Han as well? You mentioned that one of the latest study from Europe regarding the tricuspid severity is actually more correlate with the RA size and also the tricuspid annulus rather than the RV. Yes, we encounter actually both two extreme pathology. One would be the posterior F with a severe PR if you have a gigantic RV, but very seldom we actually come across with severe TR. But on the other hand, we have some chronic rheumatic hearts with ordinary size RV but with a giant RA, and they have very severe TR. So you have any studies or research into the RV annular or the right heart annulus pathophysiology? Because that is really intriguing, isn't it? Thank you.
Yeah, it's just fascinating. Early surgical studies had actually mentioned the same thing, that early in the disease process, what they really saw was that the right atrium was starting to dilate. And pathophysiologically, I think, we end up, now at least, I end up thinking that the annulus follows the atrium. And therefore, that's why in all functional disease, whether it was atrial or ventricular functional, the TR was more dependent on right atrial, which then determines tricuspid annular size. And when you look pathologically at the annulus, it's not like the mitral annulus. It doesn't have a lot of fibrous tissue. And surgeons may know this already, but I mean, we learned it the hard way with the Tri-Line device, where the only part that has fibrous tissue in the annulus is near the anterior commissure, behind the aorta. Other than that, there's nothing. And when I went to the cardiac pathology suite, they showed me some fresh hearts, and if you were to run your finger, and the surgeons already know this, right? But I didn't know this. If you run your finger from the atrium to the ventricle, you can't tell where the annulus is. There's no fibrous ridge. There's no nothing. And when you look histologically, it just goes straight from right atrial tissue to right ventricular tissue. So it turns out, I guess, that it's really right atrium that is primarily determining tricuspid annular size. And this was described pretty early on in the surgical literature, and I just found it recently. So I think we should have learned a lot from each other, from the surgeons. But we now have these three-dimensional imaging studies that have proven what I think you have already, what many surgeons already knew.
Thank you. Dr. Hashinohe, do you have any questions or comments?
Yes. I'm from Sapporo, Japan, and I think the timing of invasive treatment for isolated secondary TR is quite important, not to miss the good timing. So RV function may be key issue for the timing, I think.
Yes.
So I'd like to ask you about the timing of invasive or indication for isolated secondary TR. Of course, that depends on the number of factors, but we should go operation if RV function is deteriorated, or we should do aggressive assessment using exercise or dopamine stress echo. What do you think?
That's, I mean, we're still trying to figure it out too, because the guidelines, say dilating RV or, or severe RV dysfunction, but we have no idea what severe RV function is, because in point of fact, the RV is rather plastic, and you have a patient, for instance, with end-stage lung disease, and you put a lung transplant in, and all of a sudden the RV, which is completely blown out before the lung transplant, comes back to normal, in any case, we don't have a good sense of what measure will help us determine plasticity and recoverability of the RV. But I think you're absolutely right that we are taking all these patients too late, and that maybe what we should be doing is, again, sequential, more aggressive measurements of RV function, like RV strain. RV strain now is super easy to measure because we have all these automated packages. And if you start to see a reduction in RV strain, which may be picked up before we see a reduction, we don't know this yet, but this is what's happening on the left side, certainly, where we can pick up mechanical dysfunction before RVEF goes down, or fractional area change, or TAPSE, which is just longitudinal shortening. And maybe those are the patients that we should be targeting. And I think you're 100% right, but we're still trying to figure out exactly when to intervene. I think the guidelines are doing their best, but we're still going to get patients too late based on our current guidelines.
Okay, thank you. Thank you.
Thank you for the excellent talk and discussions. Instead of Professor Rvpa, we have now Professor Gilbert Tang, who will speak first regarding his lecture on trans. Okay. Okay. We have Professor Rvpa now to share with us, to stick to the schedule, to talk to us on surgical and transcatheter advancements in tricuspid valve replacements. Thank you, Professor Papat. The stage is yours.
Can you see my screen? Okay, thank you. First of all, good evening from US, and good to see that Becky and Gilbert are awake as well. It's not just me. These are my disclosures. So the most interesting thing about tricuspid valve is we don't know the timing of surgery or intervention. For aortic valve, we know when to intervene. For mitral valve, we know when to intervene, and it changes prognosis. But tricuspid valve, it's still very ambiguous. There are recommendations, however, which are still there. And you can see that the main recommendations are, if we are operating a left-sided valve, then we can intervene on certain tricuspid severity. And this is becoming more common now in terms of, it's not uncommon for me to do a tricuspid annuloplasty if I'm operating on the patient on the left side and if there is annular dilatation. The main annular dilatation, we know where it is. This is again pretty interesting because there are times we see that the annulus is dilated as large as nearly 6 centimeters. And then the dilemma always is whether to replace this valve or will it hold well with just the repair. And probably Dr. Tang will talk a bit more upon what happens to these tricuspid valves. Interestingly, many times we get a good result on the table, but there is so much tethering of these leaflets that recurrence is not uncommon. The recommendations for surgery, which I showed you before, assume a lot of things. One of the main assumption is actually that surgeons will be doing a repair more than replacement. And when we say repair, is majority of the repairs are generally annuloplasty. And we also assume now that annuloplasty will be done with some kind of ring or band rather than a suture-based repair. And again, we can see that these pacemaker rates are not affected. If we do a replacement, of course, there's a high percentage of pacemakers. Hence, the replacement in general seems to have higher mortality. And I think a lot of it is to do with these patients have very large RVs and quite terminal or torrential TR. Pacemaker leads also pose a very important challenge. In my practice, at least what I do is I see if I can free the pacemaker leads and then lateralize them in one of the commissures, and then see if I can get good cooptation and floating of the leaflets to achieve a reliable repair. The main problem is current rings which we use. If these patients come back with TR, we have no option of valve in ring, as all these rings are incomplete and majority of them are actually rigid. You can see that here I'm showing you the Mayo Clinic experience with pacemaker-induced TR. And you can see that at least 46% of patients underwent replacement rather than a repair. And in replacement, the choice of the replacement was both. However, tissue valves were much more than mechanical. This is to highlight that the pacemaker-related TR again poses a big surgical dilemma in terms of whether we should repair or replace. And when there is doubt, it's better to replace. Of course, it depends on age of the patient as well. There are times when we do leaflet augmentation for definitely these pathologies. The main leaflet augmentation is of the anterior leaflet, and the repair is based on that anterior leaflet co-opting well with the other leaflets. You can see here that the mortality and the PMR is very high. Replacement is generally preferred for tethered leaflets, large RVs, and again, pacemakers. The main discussion always is mechanical or biological. I think this debate is pretty well settled now. Majority of us prefer biological valves. But again, whether porcine or pericardial valves, and this completely depends on surgeon's preference. You can see here the US trend for isolated tricuspid valve surgery. The in-hospital mortality remains 8.8%. Repairs are done in 41 and replacement remains pretty high. And again, if you look at the mortalities for different groups, replacement tends to have much higher mortality than that of repair. And I think the pacemaker rates for these are also high. So I think going back to this background, that if I'm going to do a tricuspid valve replacement in a patient who has already had a left-sided surgery or a CABG or any valvular surgery, then does it not make sense today to try some device to replace the tricuspid valve? These are the 4 devices which I've had first-in-man experience. There is also a 5th device I'm going to show you who has had recently few cases done called a V-Dyne device. But let's go to the first device, which is Navigate. There are at least around now, I would say around 60 cases done with this device. This device it's very large. It can come as big as 54 millimeter size. It has got 3 pericardial leaflets. The main beauty of this device in my mind is, despite the large diameter, the height of the device is not that much, which is pretty unique. This is one of the cases we did in Columbia University with Dr. Han as well as Dr. Kodali. And we can see here we put a confida wire in the left and we put a pigtail through the IVC. In this particular patient, we did a mini thoracotomy as we do it for mini MVRs or tricuspids. A purse string suture was placed on the right atrium. And then right diaphragm in this patient was very high. And this was just pulled down, retracted with a couple of sutures. You can see here that we passed a wire. This is a pretty straight shot. If you get the right access on the right atrium, and you can see again here, we are passing the wire under fluoroscopy guidance. Once that is done, the delivery system is introduced. It's around 42 French delivery system. So it's pretty big at present. And then under, I think Dr. Han just gave an excellent talk on echo and different views. And you can see the benefit of these views, which are very critical in my mind in tricuspid, as landmarks such as right coronary artery are not very reliable. You can see here that the valve is released under fast pacing. Slowly and surely, fast pacing is not needed for these devices. This, in my mind, is one of the best pictures I have seen after any tricuspid valve implantation. You can see there is absolutely no leak. And again, Dr. Han might remember this was a 91-year-old female patient who did brilliant. And within 3 weeks, she was on the dance floor in a local community. Intrepid device is a Medtronic Intrepid device, which has been essentially done for mitral valve. However, we can see slowly that the evolution of this device has been from transapical access to transfemoral access. And hence, I think there was a natural progression of this device to use it for tricuspid as well. We have got the first experience was, of course, transatrial, which was done again in Colombia with the same team, and then transfemoral, which was again done in Colombia and Piedmont Hospital, and then EFS has now been started. This is a dedicated delivery system and a recapturable and retrievable device. There's less interaction with pacemaker wires if they're already present. This is still a new subject. We still don't understand it fully. The main limitation, I would say, is that there are only two sizes, 42 and 48. And as we see, majority of the patients who come for this therapy at present are patients with very large annular sizes. And the fluid changes can change these sizes as well. So we are still understanding a lot in terms of, do we need an extra size such as a 52 or a 54 millimeter device? You can see that this was one of the first cadaver testing we did just to understand how the fixation will work. And this is pretty unique because this is a low pressure system. The fixation is actually, we don't need that much oversizing. Just to give you an idea, for mitral, we at least want 10 or 15% to 25% oversize. For tricuspid, we sometimes go up to 0 to 5% oversize. This is the dedicated delivery system I spoke about. And on the far right side, you can see the first case done in Piedmont Hospital transfemorally. This is just a clip of a procedure for sake of time. I'm going to jump certain steps. This is the transfemoral system introduced. This is a delivery system without a guide wire. And again, this is again aided completely by echocardiography. And as Dr. Ahn said, that it's most important to avoid a septa hugger approach. Again, the capsule is placed with echo guidance. And then once you achieve a good position in terms of your trajectory, you open the atrial brim. And once your trajectory is good, you adjust your level of deployment, which is to be around 4 millimeters above the annulus. And then once you are happy with that, you deploy the device, as you can see here, and then retrieve the capsule and the delivery system. The initial cases we have done are all with a cut down because again, the delivery system is around 40 French, and we don't want to have problems such as venous thrombosis, bleeding, etc. And these patients also can be then anticoagulated immediately next day. Evoke is the Edwards device, which again has come from Cardiac device, which was essentially a mitral device, but has been very nicely adapted to the tricuspid. It has the smallest caliber delivery system at present with a beautiful double articulation. And the main thing about this device is it has anchors which go around the cords, and hence best trajectory is very important. The TRISCEND study for the PIs, Dr. Kodali as well as Dr. Hahn. This is the study which I think the largest number of tricuspid patients treated in the world at present. But the initial data from 56 patients have been extremely encouraging. As you can see here, not just there's elimination of TR, but very low incidence of pacemaker as well. Again, the main limitation of this device, as with Intrepid, is sizing at present. But our hope is as this therapy gets better, we are going to treat patients sooner than patients where we see at present clinically. Lux Device is a device made in China. This has a wonderful and a very unique design. It has got a RVOT, you can see, or a muscular tab, which kind of stabilizes this device. And the idea behind all this is that it has least interaction with the annulus and hence less chance of any damage to surrounding tissue. This is the particular design. The initial series of 35 patients which was presented had excellent results. There's not a single conversion to open surgery. These are all transatrial implantations, and transfemoral implantations have now been done as well. You can see here again, 30-day mortality for such high-risk patients is extremely encouraging. It's just 5.7%. And there are some issues as in any surgical approach initially, but these are soon going to get less as our learning curve gets better. The 1-year follow-up with this device has been really good. Lastly, but not the least, is the V-Dyne device. This is a pretty unique device, and if you can see just the shape of the device, this valve was designed to match the anatomy of the tricuspid valve so that the fixation which normally we achieve with any device with oversizing is eliminated completely. The inner valve is a 30 millimeter porcine pericardial valve, and you can see that there are some unique features such as a pop-off valve. So many times we feel that if we eliminate TR, RV is going to struggle. And in that case, you can go and puncture that to leave a significant leak and then probably train the RV to get used to. And that's the whole idea behind it. This is how it looks like. There are 5 compassionate cases now done. We are going to hear more about this device as well. At present, this device is not retrievable, but you can see certain unique features of this device, such as a guide wire placement in the RVOT, and hence the tab follows that. It kind of, it's like a, I wouldn't say it actively holds it, but it kind of engages at the RVOT, and then it deploys under the tricuspid valve annulus, so to fix it against the septum as well. There are some other devices which are used for tricuspid, and one can say definitely that the Sapien platform has been used cleverly in hundreds of places. You can see that they have been used in SVC, IVC, etc. We also have some contributions in that field, especially if the IVC is extremely large and you can't use a Z stent. We have done something like a hybrid surgery in Colombia, for example. But here, there's a case with a Z stent, which was used as a scaffold in such a large IVC. And then just to ensure that we are not going to cover the hepatic veins, these therapies may be palliative in my view. However, for patients' quality of life, they are fantastic. We have seen patients living up to 2 years with less diuretics and less hepatic issues, and this really changes their lives. So for burnt out patients where we can't do anything else, I think this is still a very good therapy. As a surgeon, I must say that this is my first case ever in Colombia, again done with Dr. Han and Dr. Kodali. Here we exposed with a right thoracotomy IVC and cut open a mitral ring to put around the IVC, as the IVC was around 4.8 centimeters. And this is a physio ring which we have put around the IVC and sutured it to the diaphragm. And then we know that a 29S3 works beautifully in that. This patient again is one of the patients who lived up to 2 years, and his pulsatile liver had disappeared on the table. So definitely there is a role for these therapies if we don't have any other options. The Ttmr approaches can be mainly, I think, now limited to inferior vena cava. Superior vena caval approaches are few, and transatrial approaches are initially when the sheaths are and the sheath sizes are larger. Right atrial access, as you can see, we always do a CT planning. I think CT planning has now become a mainstay of any transcatheter device, and it's nice to see as a surgeon 3D anatomy as well as cross-sectional anatomy and correlate it with what you find on the table. Transjugular, I think, is challenging because just with the sheer trajectory, because this is the annulus, and when you pull it up, it goes in the wrong direction. Essentially, you want a perpendicular direction. And I think this is the reason why transfemoral delivery systems are winning. It's not just because the IVC size is larger, but because you can do a double curve and get a coaxial deployment by this approach. Finally, this is my last slide. There are some challenges as well. There is a lot of debate on should reduction in TR be better for the patients or elimination of TR. I think we are going to see more evidence of this. My feeling is if you have options such as a clip, you don't burn bridges. You can still do a TTVR, but as we see patients sooner, maybe TTVR becomes a very good option for these patients. There are challenges, and one of the challenges being pacemakers, the other challenges being durability of these devices, as well as need for anticoagulation, as most of these patients still receive anticoagulation for at least 3 to 6 months. Thank you.
Thank you, Professor Bapak, for the insightful lecture. Professor Rvpa has introduced to us a number of novel devices and surgical prostheses for the tricuspid position. But it has always been a decade-old debate between tricuspid valve repair versus replacement. So without further delay, let's introduce our next speaker, Professor Gilbert Tang, who will talk to us about transcatheter tricuspid valve repair before we have further discussions on the topic.
Great, thanks very much for everyone's and for the invitation. It's great to see my colleagues and friends here. This year, hopefully we'll see each other in person next year. I'm going to have the organizers run the slides. I think there's some connection. So I'm going to talk about repair, and Vinny already talked about replacement. Next slide. Next slide, please. Yeah, these are my disclosures. Next slide. So Vinny already gone over the recent US and European valve guidelines, and most of the valve guidelines are focused on tricuspid repair, as you've seen here. Next slide. And these are the European guidelines. And next slide, please. And you can see the principles of tricuspid repair are threefold. That's like the mitral repair. So want to ensure leaflet coaptation and mobility. You want to stabilize the annulus and avoid conduction injury. And so you can see here the tricuspid repair techniques have actually evolved over the past 50 plus years. It started off as plication, K technique, then you have a kind of a clover leaf or edge-to-edge technique. Actually, we now use for transcatheter repair. There's the Vega, which is a suture-based annuloplasty, and finally now I think the standard in the operating room is a surgical rigid or semi-rigid annuloplasty. Next. So you can see here the second TR, which was mostly encountered recently combined with mitral surgery. We started off, as I mentioned, bicuspidization, essentially eliminate one of the leaflets. And then, however, during the 1970s, the Vega has become very popular because it's very quick. It's a suture-based repair from pledgets from one commissioner to the other. And they've been now also modified the Vega with interposed pledgets. But however, I think everyone recognized since Carpentier developed the ring annuloplasty that would be shown to be more durable, and it went from remodeling now to reduction annuloplasty. Next. So this is a paper that we recently published on basically the review of tricuspid repair at Mount Sinai. We're very aggressive about treating secondary TR in the presence of surgical mitral repair. Next slide. So you can see that the transcatheter tricuspid repair landscape is actually pretty similar to the surgical tricuspid repair in its evolution. There are direct suture annuloplasty, there's the red ring annuloplasty, there are also edge-to-edge repair to increase coaptation, and Vinny already talked about the replacement platforms. Next slide. So I think there are a number of challenges in terms of device and trial designs. I think as Becky and Ines mentioned, the population is quite heterogeneous. They often have mixed disease, not just isolated tricuspid disease. Imaging obviously is a prerequisite in terms of repair. And interestingly, it varies from device to device. The anatomic criteria also vary from device to device. Clinical endpoints can be hard to define. Mortality obviously is an easy one, but there are other surrogate endpoints that are harder to identify. And of course, if you have significant residual TR, it may still carry a poor prognosis. Next slide. So, well, the most common experience, I think, with tricuspid repair is the edge-to-edge repair, because the mitral clip system is already commercially available for the last 10 plus years. People have been doing it off-label. The Abbott TriClip G4 system is already CE mark, is commercial use, and we currently have a pivotal trial in the United States. The Pascal system is always all CE mark, and currently I think is under clinical trial in the United States as well. The outcomes have been highly variable based on anatomy and pathology. Next slide. So this paper we just recently collaborated with the Yale group. It's basically a step-by-step guide doing a tricuspid edge with the commercial mitral clip system, because as I mentioned, in the United States at least, it's not widely available in clinical trials. So this is kind of nice how to guide for those people who don't have access to the TriClip system or the Pascal system. Next slide. So you can see the TriClip G4 system. It's similar to the MitraClip G4, but the device itself is a bit different. You can see one of the knobs actually went from the clip delivery system to actually the guide, because it allows it to be better steering and be more coaxial to the tricuspid valve. Next slide. And you can see in the pivotal trial for the Triluminate in the United States, there are two arms. There's the randomized arm and single arm. And you can see that it typically depends on the anatomy and the expected TR reduction. So randomized arm, you adapt it to be smaller, and also you would expect the TR reduction to be moderate or better. If you have other anatomical challenges or imaging challenges or large gaps, and you expect to reduce TR by only 1 grade or greater, then you'll likely be in the single arm. Next slide. So I'd just like to give you a case of one of early patients in the pivotal trial that we treated, 87-year-old, multiple ablations, high risk for tricuspid surgery on optimal medical therapy. Next slide. So you can see this is the 4-chamber view. Becky's already gone through those views. I'm not going to go into details. Next slide. So this is the typical what we call the RV infix plane. You can see there's a gap there with the TR jet. Next slide. And this is we do the sweep of the tricuspid valve using this RV info explain. You can see where the jet is located and the septal leaflet and the anterior leaflet. Next slide. And you can see as you sweep across the posterior part of the valve, you can see the jet also present. Next slide. This is the transgastric that Becky mentioned before. This is with color. You can see the jet is relatively localized to the anterior septal segment with a posterior septal involved. Slide. So this is a 3D multiplanary construction that Becky mentioned again is very helpful in terms of at this say able to identify multiple planes. Next slide. Next slide, please. So you can see the clip is very important for this is before the G4 system was available. You can see that the clip has to be perpendicular to the annular coaxial. Sometimes when we set up where the clip come across going towards the anterior data, so maybe in those cases, perhaps inserting the delivery system from the left femoral vein rather than the right femoral vein might be helpful to gain the height and make it more coaxial. Next slide. And you can see it's important to confirm the insertion here. Once you grab this is anterior septal as you see in the plane. It's still playing on the same slide on my screen. Is it advanced? Okay, there we go. So you can see the you close the clip and then you assess the TR in this view, but you also will go into the Transcatheter view, which is next slide. So you can see here the most important thing in the Transgastric view, and Becky has alluded to this, is that you need to make sure you see a double orifice here because the tricuspid leaflets are thinner than the mitral. So you need to use multiple assessment to confirm that you have sufficient leaflet insertion before you deploy the clip. Next slide. What we do actually, in addition to echo, is to use fluoro to help. Just like the mitral clip, we do try to make the procedure more efficient. Before you enter the right ventricle, you see that what the trajectory looks like. And when you enter the right ventricle, atrium, you want to make sure the tank deviates towards the interceptal commissure, or you helping clip this altered. You want to be parallel to the first in the same location. Next slide, please. Yeah, next slide. So this is the second clip. We use the NT instead of XT. I think because of the mechanism of the TR there and the leaflet length. So you can see certainly you want to, on the transgastric view, put the clip exactly the same orientation as the first one, assuming the first one has not twisted the valve. Next slide. And again, you can see the similar view. You want to be perpendicular to the annular plane with the shaft of the device to minimize any challenge in grasping. Next slide. Next slide, please. So you can see this is the final result on the 4-chamber view. Next slide. So you can see ideally both clips should be in synchrony. You should not see any excessive movement. That usually means that you might not have enough grasping and you might risk SLDA. Next slide. Next slide, please. Yeah, so you can see this is the transthoracic echo. The left image is before and the right image is after. Next slide. That's fine, you can keep going. You can see the difference in terms of the repair result. And this patient actually is 2 years out now, and she's done very well. Next slide. And you can see it's important on transthoracic echo as well to look at multiple views. So actually, they're dedicated tricuspid protocol to acquire these transthoracic images. Next slide. So I just want to show you some early feasibility data that was recently published in JACC that I was part of. You can see that at 1 year, the TR reduction has been sustained. You can see certainly there's a different scale of TR reduction, but most of the torrential TR were able to at least reduce 1 to 2 Gray. So I think clinically it was meaningful, even though echographically it was still could be severe. Next slide. And you can see what more importantly is that this sustained right atrium, right ventricular remodeling in these patients, which I think physiologically these patients are quite improved, and we actually normal. It's actually mild TR, so actually this is a very promising therapy and clinically meaningful. Next slide. So I want to just shift gear to another edge system. This is the Pascal system. You can see there are 2 different sizes. Next slide. And like the mitral clip system, this has a central spacer. This is similar to the Pascal system for the mitral valve, but they have to design a system for the tricuspid. Next slide, please. So you can see this is still early data, and you can see that similar to the mitral clip, the TriClip system, the TR improvement, the echocardiographic outcome 6 months are very promising. Next slide. And so that the class 2 TR actually trial is now currently in the United States, currently undergoing randomized pivotal trial similar to the Triluminate. Next slide. So there's some direct annuloplasty system. This is commercially available in Europe. This is the cardio band system. They have a similar one for mitral. Essentially, it's a flexible annuloplasty band going from one commissure to the other, and with anchors placed at the tricuspid annulus. Next slide. Again, very early data being shown here. 30 days showing sustained TR reduction. Next slide. But also interestingly, the annuloplasty effect remains the case. And you can see there's also an improvement in RA and RB remodeling. Next slide. Okay, and you can see that this is a European study, which is a continued access study for a tri-band study that are tracking these patients. Next slide. And there are a couple other first-in-human annuloplasty devices. I'll be wrapping up here shortly. It's the Millipede, which is both combination of TE and ICE guidance. There's TriSync system, and then the MIA system, which is multiple anchors along the tricuspid annulus. Next slide. And Beanie's already talked about the replacement system, so I will skip the next the final slide, please. So I think we need to figure out which stage of the RV physiology the patient is in to decide which therapy is better for the patient, whether it's repair or replacement. Next slide. So in summary, I think the transcatheter tricuspid therapy are gaining momentum in clinical study, as you've seen. Early results with edge-to-edge certainly have some encouraging results with the positive RV remodeling, but I think they're still limited to patients with smaller gaps, no really cardiac lead interference, and good imaging. Annuloplasty, as you see, is still very, very early, more complex to do, but maybe more physiologically relevant. And I think with Vinny, replacement probably be simpler to do, especially in larger gap patients or advanced right ventricular disease. But there's issue anticoagulation or RV remodeling with such a large device in the ventricle. Next slide, and I'd like to thank you very much for your attention.
Thank you, Professor Tang, for the insightful lecture and the beautifully done cases with excellent results, both clinically and imaging-wise. So we're now open to discussions. So may we start off with Professor Kentaro Hayashida. Do you have any insights or comments on how you manage tricuspid valve regurgitation?
Okay, thank you very much. And thank you very much, Vinny and Gilbert, for the very fantastic presentation, as always. And actually, we are studying the TriClip study in our country very soon, and your presentation is quite relevant to us. And I would like to ask a question to Gilbert that if you think about the TriClip procedure, how many % of the patients are excluded because of the difficulty in imaging or difficulty in the clipping? What is your thought?
Yeah, well, we all learn from Becky and her group. I think that's what we've done, is to really try to optimize the patient. So for example, at least in our center, we have cardiac anesthesiology to sedate the patient. So you go into a little bit deeper sedation to minimize the movement and respiration, to try to get better imaging by positioning the patient in different ways. And that has actually been very helpful to us. I think this is really important for patients with, let's say, previous TAVI valve, previous mitral valve, or mitral repair, or aortic valve prosthesis. Those can be very difficult because we see them a lot because they never fixed the tricuspid valve because it was forgotten before. So now we have to deal with it. I think so that has been helpful in terms of image acquisition. I think we also are very particular about having the same imager to take the images at the time of procedure as well as at the time of screening, so we have consistency. So again, I think that has been very helpful to us as well.
So maybe, Becky, do you have a comment?
And I'm actually starting to become a much bigger fan of going from the left venous axis rather than the right node. Sorry. Yeah, no, I just finished my thought saying that the left venous axis may be able to gain height and avoid a septal hugger, which has been probably technically the most challenging aspect of edge to edge, in my opinion.
Thank you.
I do have a question regarding repair versus replacement. Assume that we have both devices available. So we know that in severe tricuspid regurgitation, there will be abnormal remodeling of both the right atrium and the right ventricle. If we treat the TR, because the right side structures are relatively flexible. If we repair the TR and then reduce the TR, and then would there be reverse remodeling versus if we put in a valve with a fixed size, will that affect the regression of the dilation of the right ventricle and right atrium? Is there anyone who has insight on this?
I think the surgical literature hasn't investigated it in the same way as we want. As you know that surgical valves, the biggest valve available was 33 size, which still the external perimeter, I would say, is around comparable to 43 to 44. So we tend to bring the annulus inside in surgical valves by sutures, while in transcatheter valves, we are oversizing it a bit. But I think if you look at the RV structure as such, I think other than the basal remodeling, I think the rest of the RV should remodel because there is obviously a volume reduction now on the RV, as well as there will be benefits in terms of pressure reduction if pulmonary hypertension, especially the reactive pulmonary hypertension, goes down. So I think there's still a lot to learn on that. Main advantage of repair, at least I feel, is that you don't burn bridges. And till we understand how all this is going to play out, it is a safer therapy to use in the current form.
I was just going to say that, you know, the problem with the TEER device is that, you know, one wonders whether you've burned a bridge, you know, as far as not allowing replacement anymore. But there are new devices out there now that are attempting to be able to remove the clip. Actually physically remove it out of the body. So maybe we're not going to close off the avenue for transcatheter tricuspid replacement devices with a TEER device. But getting back to the question about RV remodeling, I think you know, Vinny's right that although the devices are rather large and at the base there may not be remodeling, what we've already seen with some of the Trisend devices is that the rest of the RV starts to remodel. And remember that, you know, if you can reduce even the RV outflow tract, the RV outflow tract for the RV contributes in a normal patient maybe up to 25–30% of the cardiac output. So that's not going to be affected by these, maybe not the B-dyne, I'm not going to speak to the B-dyne, but the other transcatheter devices, replacement devices, you know, shouldn't affect the remodeling of both the midsection, apex, and RV outflow tract. So I do think that we're going to see some benefit from those devices, even though they look rather large in the annulus.
I have a question about the HKvalve valve implantation, because this device is recently now also available locally here in Hong Kong. So my question is that because we know that HKvalve valve implantations correct the symptoms, but it does not really correct the problem of tricuspid regurgitation. And therefore, I bet that the hemodynamic consequence of a TR is still there, or electrical consequence of the TR is still there. So do you have any experience or data or advice recommending which kind of patient should receive a HKvalve valve implantation instead of a tricuspid valve repair or replacement?
I think at least the patients we have done up till now are the patients where any available current therapy is not possible. And when I say current therapy, it is geographically not available. For example, in United States, there are 5 devices which are undergoing a EFS trial. But say in Europe or maybe in Asia, you may not have those. So you still have to work around it. I still very strongly believe that although you are not addressing the tricuspid valve directly, just by reducing the volume regurgitation into IVC, which is, I think Dr. Han will tell us that they say IVC reversal flow. So you reduce that volume burden. Now, I would have thought, and this has always been my thinking, not just the SVC, you put another valve in SVC, but actually the main thing to do in these patients is to put a plug in the azygous vein. Because azygous vein is the vein which connects both the systems, and that's still going to carry some regurgitation if you just put a valve in IVC. But I think there are limitations in these patients. I completely agree. They are totally, I would call them like a burnt out patients where life expectancy is not that much. And what you are going to do is mainly symptomatic treatment. The other thing is the renal vascular hypertension might come down and maybe the diuretics will play better. You need not increase the diuretics that much. So it just helps you to manage patients. If you don't have any other option, it's still a very good option to look at.
Hello, this is Daniel, cardiac surgeon from Hong Kong. Nice to see you again, Vinny and Gilbert, and excellent talks as always. So I got a question for both of you. As a surgeon, we always try to avoid to do the TVR if possible. Is it still the same idea in the transcatheter therapy? And second question is that among all those devices you two mentioned in the coming futures, if you want to pick one with the highest potential or the most useful one, which one will you pick and why?
I think I think the second question I'll answer first. It's politically incorrect to answer that question. We are still in a very early phase and each device is pretty unique, and I hope my presentation was very balanced in terms of showing the downsides of each device as well. Like, for example, certain devices have better delivery systems, less caliber, certain devices interfere with, but they need a extremely perfect implantation, while certain devices are forgivable, but at the same time have bigger delivery systems. So we are still in really early stages, so I wouldn't go answer that question. But secondly, about repair and replacement, currently the tricuspid repair essentially is based on the cliff philosophy. So I think we, as a surgeon, we rarely do that. We just do annuloplasty, right, to reduce the annulus to increase coaptation. I think let us see how this all plays out. Means early data has shown some benefit, but I think reducing TR to less than moderate at least is going to be key. So good patient selection for each therapy in my mind is going to be very important.
Thank you. And Gilbert, what do you think?
Yeah, no, I agree with Vinny. I like what we do in the operating room. We don't just pick, one repair technique and that's it. So, and I think right now the issue is direct annuloplasty is just too challenging from percutaneous standpoint and time consuming to do well. I think hopefully with new imaging like ICE and complementary TEE, perhaps with some more advanced imaging modality, it will make the procedure more reproducible and simpler. There'll always be a role for replacement, just like what we do in surgery. I think the question is whether it's beneficial to the patient. And I think those patients with very advanced right ventricular disease and large gaps, you're not going to be, we don't repair them in the operating room, so we wouldn't repair them from a transcatheter standpoint. I think if the imaging is good, as Kentaro mentioned, small gap, I think edge to edge is very reasonable, kind of like the mitral side, right? If the transeptal anatomy is good, straightforward mitral anatomy, I think TEER is a very safe and a very effective option. But I think we need more than one toolkit for the tricuspid because the patient population is just too heterogeneous.
I do have a question for Professor Tang and other expert panelists. Suppose we do have a lot of patients with CIED-related pacemaker lead impingement. Oftentimes, the septal leaflet is impinged. How would you treat these patients with the tricuspid clip system? Do you still go for the anterior septal commissure, or do you prefer the triple orifice technique like suturing the AMP and then the ANS leaflets?
Others that chime in too, and Becky being a co-laborator has looked at hundreds of these. I think it depends on where the lead is positioned. If it's tucked in a commissure, we've seen those. We actually, and the gap is small because the TR is not part of the jet related to the lead directly. We actually have approved them for randomization in the triluminal pivotal trial. However, once the lead is in the center, especially ICD leads, which are much more echogenic than just a regular pacemaker lead, and if actually tether the septal leaflet down so that you can't bring the septal lead, that's when is more challenging to tackle with an edge-to-edge device. If the lead can be removed, we sometimes ask them to remove it if it's mobile and not tether and potentially risking leaflet injury. But if the lead is not removable and there's a jet next to the lead, but sufficient enough, we can reduce the TR by at least 1 grade, we would approve them to single arm. So, and of course, the imaging aspect has to be critical. Becky, you want to comment since you guys have looked at so many of these cases?
Yeah, I mean, it's thanks, Gilbert. It's a great question because, in our clinic, at least something like 20 to 25% of the patients have a lead. So if the lead is actually impinging, so it's fibrosed to the leaflet or it's impinging on the subvalvular apparatus, which is not uncommon as well, and that is the etiology of the TR, then those patients are typically not candidates for a TEER device because you can't actually grab at the site of the pacemaker lead. But as Gilbert already said, if you can move the lead, you can remove or move the lead, then you have a shot at TEER. But the transcatheter replacement devices don't care. And so we've done any number of cases now of patients with clear impingement or adhesions of the pacemaker wire to the leaflets or subvalvular apparatus and still been able to get a transcatheter replacement device in. And remember, we currently have these 2 replacement devices, one in pivotal trial, the Evoke, but the Intrepid is just it's a beautiful valve, right? It's got 3 levels of tines. Vinny can speak more about this valve. And so again, it's not going to rely upon grabbing a leaflet or being under an annulus or anything like that. So I think for those patients, I think transcatheter replacement devices are a great option.
We understand that although for a tricuspid clip or edge-to-edge repair device, there might not be single leaflet device attachment. However, there might be some bouncing and motion of the clip and the leaflets. And when the clip hit the defibrillation lead, will that induce any noise or even inappropriate shock in your experience? And also for tricuspid valve replacement, if we impinge the defibrillation lead, will that affect the longevity or even induce inappropriate shock in these patients? Any one of you has encountered any similar case, or is it just theoretical?
No, I think. Oh, go ahead. I think with the replacement.
Sorry. Yeah, no. I don't actually know. We've not seen any change so far in either impedances or lead function, but that doesn't mean we're not going to see it. So I think it's a great question, and I don't know if either Vinny or Gilbert have seen it at all. So far, we've not. But remember that with a replacement device or with the repair device, we're kind of we're trapping that pacing wire, and so they have an incidence of endocarditis that may become a problem for us in the future. But I haven't seen any lead dysfunction yet.
Yeah, I think that the challenge. Sorry, Vinny, I'll just chime in on just specifically for the edge-to-edge. I think the challenge, and I think Becky can also mention, is that when you're doing the procedure, you're under general anesthesia, you're under fixed tidal volume. The patient is not standing up, taking a deep breath. So you think you might be okay, grabbing very close to the lead. But once you, stand upright, the patient starts to walk and become, different in terms of it might potentially interrupt it. I mean, thankfully, I don't think in the trial we haven't seen any, embolization or things that I know of. But certainly you have to make sure that you safely a distance away, because especially the mobile leads. If the tether leads, I don't think you're as worried. Sorry.
I think the other important question is with the transcatheter replacement devices, twofold is one, as rightly pointed by you, we have seen some cases now where there is a tension on that lead because just the design of the device, and they need close monitoring. But the bigger question is, if you have a need for a pacemaker after implant, then how do you place it? Because the last thing you want to do is go through the newly implanted device. So we have currently done a coronary sinus lead, for example, Micra has been done in cases of transcatheter valves. And now that's why there are these design features which are there in, say, V-Dyne or Intrepid, where there's a gap between the two stents. Can you exploit that and use the technique which we are using essentially for Basilica or Lampoon, just to use a small hole and put a pacemaker through that? So there's a lot of background work we are doing on this. This is just the beginning of the understanding of different challenges, I think, not just physiological, but anatomical as well.
And I think we have one final question from the internet. For patients with pulmonary hypertension, we understand that for all kinds of transcatheter edge-to-edge repair or replacement, there might be worse prognosis. So do you have a cutoff in terms of RVSP or mean PA pressure, or will you use medications such as phosphodiesterase inhibitors to lower the PA pressure in order for you to proceed with the tricuspid intervention?
I think that question is for Becky.
Yeah.
We just listened to her.
Yeah. The current inclusion and exclusion criteria for most of the trials do put a limit on the pulmonary artery pressure. And it's not because of any tremendous knowledge that we have about those patients, except that we know that they have a poor outcome. But the cutoff varies between 60 and 70 millimeters of mercury. And then with some using a PVR cutoff, pulmonary vascular resistance cutoff. And so, again, it's not that we have any tremendous knowledge about, where's the cutoff, where the cutoff should be, but it's an attempt to not treat those patients that we know their outcomes are going to be determined actually by the pulmonary hypertension and not by the TR. So I wish I knew, but we're also looking at things like Rvpa coupling. And Rvpa coupling is just, how well the RV can manage the PA, the pulmonary hypertension. And if it can increase its mechanical function in response to the pulmonary artery increase in pressure. And once you become uncoupled, we do believe that those patients may not be the ideal patients to do the device in, but we're learning more about that, during these trials.
I think, Becky, would you agree that there are some patients we have seen that where the PA pressure is not that high, but the RV dysfunction is more, and then we are worried actually these patients
Correct.
don't do very well.
Yeah, 100% correct.
Especially with complete elimination of PR.
Yeah, we just looked at it. Should be coming out in JACC Interventions, I think, on Monday. But we looked at, the TriValve registry is not going to be coming out yet. It's the COAP trial that's coming out on Monday. But when we looked at the TriValve registry for Rvpa coupling, it's exactly as you say, Vinny. It's because they've got hyperdynamic, what looked like hyperdynamic function because of the low pressure TR. If you don't start off with a coupled Rvpa coupling number, then you don't do well. And the ones that actually start off high and reduce their Rvpa coupling, but have the ability to reduce it, actually do the best. And that the ones that start lowish and don't change are the ones that do the worst. And so it's really, as you say, we're looking for patients who kind of are hyperdynamic, maybe because of the TR, but have enough Rvpa coupling that they improve their forward stroke volume after the TR is reduced.
So thank you very much, Professor Han, Professor Bapak, Professor Gilbert Tang, Professor Hayashida, Dr. Hashinohi, and all our expert local panelists. We come to an end of the first session of the tricuspid valve intervention. Thank you very much. And we now move on to our next session.
Thank you.